So for those of you that didn't hear before, my name is Cornelia Griggs. I am a pediatric surgeon at Massachusetts General Hospital, and I'm also the education lead at our Center for Gun Violence Prevention and an assistant professor in surgery at Harvard Medical School. I have to thank my team as part of this work. All of the data that's being presented here and all the work that went into conceiving and executing and implementing this project is due to my awesome team, Gretchen Filopoulos and Amy Kaplan, who work with me in the Center for Gun Violence Prevention at MGH, and Robin Kogan, who is really the inspiration behind this project and a longtime advocate and an incredible partner of ours at the Center for Gun Violence Prevention. Our team has no disclosures. So I'm going to start just by generally giving an overview of how our center and I view the clinician's role in education when it comes to gun violence prevention. In 2019, the MGH Center for Gun Violence Prevention was launched with a mission of focusing on clinical care, education, research, and community engagement. We shared the belief of many others that gun violence is an urgent and devastating public health threat, and as both counselors and first responders, clinicians carry a responsibility to work to prevent gun violence. Nowhere is this more critical nor its effect more immediate than at the bedside, where at times it may be appropriate for clinicians, doctors, nurses, MAs, anyone at the bedside to do three things: to ask patients about access to firearms, to counsel patients, parents, and families about the safe use and storage of firearms, and three, if necessary, to intervene to thwart harm. However, lack of training has been identified as a significant barrier to conversations about gun access and safety in the clinical setting. Even among postgraduate medical training programs with an emphasis on preventative medicine, the vast majority, about 75% of programs, provided no training related to firearm injury prevention. An analysis of our own healthcare system and our electronic medical record demonstrated that among over 80,000 consecutive hospitalizations using natural language processing to review the charts, alcohol was mentioned in about 69% of encounters. Tobacco was mentioned in about 50%, and this is broken out by specialty in this slide. However, any discussion of firearms was identified in just 425 encounters, or about 0.5% of those encounters. Even more concerningly, in a retrospective review of pediatric patients who presented to our hospital's emergency department with active suicidal or homicidal ideation and who were seen by a pediatrics resident, this was measured over a 12-month period, only 5% were asked about access to firearms by the treating emergency department resident. And in a quarter of those cases, no discussion about firearm access was documented in the medical record by any clinician before the patient was discharged. So since 2019, we've been on a mission to change education around gun violence prevention in the clinical setting at our hospital. And we've trained nearly 1,000 interns across departments through a novel case-based simulation training program. And you can see some of these bar graphs over to the side showing improvement in sense of comfort level with these conversations and counseling after our trainings. Our curriculum is available here and has been published and shared with many partner institutions. And if your institution is interested in implementing this training, we'd love to partner with you. And I'll share my contact information at the end. I'm also excited to report that we're now deploying this curriculum through an avatar-based platform to make it widely scalable nationally over technology. So devastatingly, we know that gun incidents at school are on the rise. And I'm also going to include the oft-shared statistic that gun violence became the leading cause of death among children and adolescents in 2020. The crisis surrounding school shootings demands creative solutions. And we put this proposal together knowing that school nurses are a powerful and underutilized resource as credible messengers in the gun violence prevention space. School nurses serve as a link between hospitals, schools, and communities, and are also working on the front lines of the youth mental health crisis in schools. We began our work in the first phase with information gathering. This is a novel curriculum and kind of uncharted territory. So we started with two nationwide focus groups led by Robin Kogan, our favorite relentless school nurse and gun violence prevention advocate. And we also included 4 one-on-one interviews with participants who had expertise in this space. This is our flyer over there on the side. And we learned a lot from those focus groups. The themes that came out as a result of those focus groups really guided our curriculum development and the ultimate modules for the training program. And we learned a lot through those focus groups that will serve as future directions for this work as well. We learned that nurses are undervalued and underutilized for their roles and expertise in schools. We learned that there was an overwhelming sense of a lack of safety in school, and many school nurses reported that they felt gun violence at school. It's not only possible, but in some cases inevitable. There was a hunger for training for how to prevent gun violence in schools, and a lot of nurses felt that training was missing, but that active shooter drills on the other side were pretty common. A lot of nurses reported that they felt an absence of an action plan in the case of a gun incident at school. And we heard over and over again that the mental health crisis is devastating and widespread among our nation's teens, especially. Phase 2 of this work was embarking on a pilot training. Based off of our successful training with residents at MGH, we developed a training curriculum to use with the school nurse population. And the training curriculum started with a 20-minute didactic lecture-based format with slides and 2 case-based scenarios that were run with standardized patient actors that gave all of our trainees and participants a chance to practice with a case-based sim. In the didactic session, we covered statistics in the context of firearm violence in the United States. We discussed the definition of extreme risk protection orders or red flag laws, both of which are in place in Massachusetts and New Jersey. And we explained how school nurses could potentially engage with those laws or encourage families to. We reviewed the 5 L's as a principle for non-judgmental safety and counseling in a clinical setting. And those questions are based off of Garen Wintermute's work, but asking if firearm owners know whether their gun is locked, loaded, if there are little children present in the home, if anyone is feeling low in the home, and if the owner is learned about common safety and storage practice. We also discussed simple methods for safe storage of firearms. This is just a snippet of a handout that we share with a lot of our trainees and participants showing cable locks and trigger locks, how they work and what their average cost is. And we discussed for having these tough conversations, tips for having these tough conversations with parents and students. This is an example of one of the case-based scenarios that we used as part of our SIM trainings. You're seeing a child in the nurse's office for a stomach ache, talking with the student. He shows you a photo of himself holding his parent's gun and brags about it. We provide some history of present illness and a case prompt, and then our participants were able to sort of practice how they would engage with this child's parents if they were put in this scenario. And a lot of our participants actually told us that this is something they see very commonly in their schools. The first training was held with 16 New Jersey-based participants from the Rutgers School of Nursing at Camden. And we found through our participants that there were a range of opinions on firearm restrictions in schools. Interestingly, more than one participant felt that teachers should be allowed to carry guns in schools for safety and to prevent school shootings. Many participants felt fairly strongly that schools should have armed security guards on campus, and many had a high degree of agreement that schools should have metal detectors to prevent guns from being brought onto campus. A lot of our participants, especially in comparison to some of our resident training programs, had previous experience with firearms at home. Several either currently owned or had previously owned a firearm, and many had lived in a home with a firearm. This graph is a nice demonstration of the change in comfort level pre and post training with 6 skills. Our participants felt significantly more comfortable asking about the 5 L's, asking permission to provide information about firearm safety to children and families, to discuss ERPOs, to introduce firearm safety in the context of anticipatory guidance, to provide information about safe firearm storage, to support autonomy by giving choices for safe storage, and to use affirming statements to support parents. Nurses overall found screening and counseling for firearms to be important, and even more so after the training than before. And this is just some interesting feedback that we got from our participants in the free text part of our survey, and definitely suggestions that we're going to use to build on and improve the training curriculum moving forward. But one participant suggested that we should give parents, students, and staff the tools to talk about it and have conversations regarding safety and keeping the community safe. Some suggested adding gun safety to annual health screening forms or providing initial screenings during enrollment. One participant said, I think yearly assemblies to educate on gun violence and safety is most important. Some suggested that open dialogue at all times whenever there are red flags was the key, and others felt that an armed police officer should be at every school open in the United States. So in conclusion, this work has highlighted the powerful role that school nurses have in primary gun violence prevention and a dire need for their advocacy in schools. Our pilot training yielded promising results, and we plan to expand on this in the future. We're hoping to give our current survey to a large group of school nurses at a national conference to gather more data, and we have 2 additional trainings with Massachusetts-based school nurses on the books for June and July. In terms of future directions, we're hoping to partner with national organizations and foundations to expand access to these trainings in schools and to iterate this process and improve our trainings to make them more effective and impactful for school nurses and counselors. We'd like to express our appreciation to the Rutgers Gun Violence Research Center for sponsoring this work, and they've left plenty of time to take some questions. Thank you, Robin. Robin said it's empowering teaching how to have these conversations to school nurses. I also found it really empowering, and I think I learned more than anyone else participating in the training, and we got so many great ideas about how to build on and expand this work through piloting this. The status of this training in New Jersey is that we, through the funding of the Rutgers Gun Violence Research Center, we were able to provide a pilot training, and we're looking for future mechanisms. I'm going to hit stop share for 1 second. We're looking for future mechanisms to expand this work throughout the state. And I agree, Robin, that breaking through the stigma of talking about guns is a wonderful outcome. We actually learned through our focus groups and our pilot training that there were many participants and school nurses who felt that they were actually being actively discouraged by their school administration to even bring up the conversation or the topic of firearm safety. And I think this was a really great start to dispelling that myth. But I also don't want to dismiss a lot of the fear and anxiety that school nurses expressed to us about bringing up this topic, especially in the wake of COVID. We really got the sense, yes, exactly what Robin is saying. School nurses reported to us that they felt silenced, that they felt dismissed, that their opinions and expertise was disregarded by school boards and administration. And I think it's really important that we focus on a sense of psychological safety at work for our health professionals in schools in order to encourage them to continue having these conversations, because I don't mean to suggest in any way that it's easy. Yeah, I'm going to share my contact information. Thank you, James. Love to partner with you in Moms Demand Action, South Jersey. We would love to partner with you. Here, I'm going to share my contact information here. It's cgriggs@partners.org. Yeah, I think we see this training program as being widely applicable and widely and easily modifiable in different settings. Obviously, one of the logistical barriers to doing this training in an in-person way is having access to standardized patient actors, because I think one of the keys to having difficult conversations in a clinical setting is having the ability to practice in a non-judgmental space, in a space where it feels safe to stumble, in a space where it feels safe to ask questions. Because I think a lot of people have trouble overcoming the activation energy of asking the question about guns or firearm safety at home because they feel they have no experience or knowledge in this space. But it's remarkable that the significant changes that we see in the sense of self-efficacy, confidence, and just generalized comfort level through a short didactic, the opportunity to ask questions of an expert. I want to emphasize that Gretchen Filopoulos, who's a PhD psychologist with specialty expertise in trauma-informed care of children, has been an incredible resource on this project. And I think her expertise in that space is something that gave a lot of our trainees and participants an additional sense of safety and comfort level in having these conversations because they learned how to do it through Gretchen. Frank, would it be something that you could do as a pre-conference workshop at one of those nurses conference you mentioned? Yes, we would love to do that. And we have actually put together a memorandum of agreement with NUSHA such that nurses who participate in our training will be granted I call it CME, but the equivalent of a professional development credit. And that's something we're really excited about. And I hope will incentivize more participants to complete our training. Yeah, contact hours. Thank you, Robin. But yes, if anyone has ideas for ways that we can offer and deploy this training on a national scale, that's where we'd like to go next. And Robin's already working on it too. It's 2 hours total, a little less, but we like to give plenty of time at the end for a debrief because I think talking about gun violence and encouraging people to have these conversations with their patients is something that, as you can tell just from our survey response of 16 participants in New Jersey, people bring a lot of different worldviews to the table. And so I think as part of this training, it's really important to build in a healthy amount of time for all the participants to debrief at the end. Even in our focus groups, we found that the conversation can be very emotional, very triggering. And we learned through our first training that it was really important to have a breakout room for people to have a space to time out, a space to kind of honor and recognize the intense emotions that are brought up by even talking about these case-based scenarios. Because we find increasingly that all of our participants and trainees are impacted by gun violence in the context of their own lives in some way. Yes. Robin said that she's presenting some of the findings at the National Association of School Nurses in July, and we'll include the survey as well. Yes. And the data is so critical to furthering this work. Thank you, James. The comment is your training appears to have great results. Really appreciate your efforts to respond to those who are on the front lines. Absolutely. That's where we want to be, and we want to provide as much support as possible. And I also want to acknowledge that this is pilot work, but yes, the key here, the key word, as Robin is emphasizing, is prevention. We want as many providers and clinicians as possible to feel that they have a voice in preventing this public health crisis, and not just responding to it on the back end of a crisis or a gun incident, or even worse, a bullet wound or a death. And I think when we engage more and more people across the spectrum in the conversation about how they can have a role in prevention, we start to give people hope. Because if you're like me and you just read the headlines day after day, it's really easy to start to feel like nothing is going to change. And I think this training is a really nice way to engage with people and make them feel that they do have a voice and a role to play in prevention. Frank, thank you for your amazing comments and supporting our work. Great. Well, it's 2:45. Oh, thank you so much, Robin. You're the muse and the inspiration behind all of it. So happy to have you here. And I think we have a break. But if anyone else has questions or wants to be in touch, please do take my email. Please do be in touch with me and or Robin. Um, we're a more the merrier kind of research team, and we'd love to have your input and collaboration. Thanks again.